Okay, this is a patient with right lower quadrant abdominal pain.
I see like a thickened enhancing bowel loop in the right lower quadrant. I couldn't tell if it was the appendix or the TI. Right there. Super thick. Oh, is it the appendix? Super thick and enhancing appendix.
Yeah, the TI is here, just medial to it.
I don't think I've ever seen an appendix like that. But like cancer doesn't usually look like that. Is that just like inflammatory bowel disease only of the appendix?
I have seen that once.
And what was it?
Inflammatory bowel disease.
Oh, IBD.
Could this be sort of like like a infiltrative carcinoid of some sort?
This was appendiceal cancer.
Damn.
Oh wow.
Goblet cell. So I was like thinking like if I were to read this case, because it is thickened, right? It's like thickened. It's not like a thickening of an appendicitis. Like how would you? This was called appendicitis and got appendectomy, and they came back as goblet cell appendiceal cancer. So went back for a right hemicolectomy.
I don't think I would call it appendicitis. There's definitely inflammatory changes around it, but like that wall is way too thick. Just
yeah, right. Like, well, how do you differentiate appendicitis from something like this, which turns out to be appendiceal cancer? So I think it doesn't have the. I think the thickening is too much. It doesn't distend in the same way, maybe, because it is distended, but not that distended. I think there is superimposed inflammation. There's a little bit of stranding around it, so it's not the fat is not, it's a little bit strandy. So I can see, I mean, maybe perhaps there's superimposed here, like inflammation. But this is something to be just keep in the back of your mind that it's, other things beyond appendicitis can have a weird, similar appearance, right? It could be definitely a mimic. Yeah.
I was just looking up goblet cell because I know that this is a subtype of appendiceal cancer. And online it says it's a rare mucus secreting tumor that can exhibit mucinous and neuroendocrine differentiation, varied course. It varies from like stage 3 to 4 disease. The reason I was kind of looking it up is signet ring cell. This looks to me kind of like an infiltrative tumor, right? Like if it was like more the apple core lesion that like, or like a more infiltrative lesion like we typically see in adenocarcinoma, that would have made me think more about appendiceal adeno. But I was wondering if goblet cell was similar to signet ring cell, which is more like infiltrative. So it can be like moving under the submucosa, spreading in a linear fashion without actually like obstructing the lumen. But I'll have to get back to you on that one. Yeah. Okay.
Okay, so this was a patient with no known liver disease. No, patient had a history of renal cancer, sorry. So was undergoing surveillance. So no underlying liver disease, undergoing surveillance. And then this is his or her, I'm not sure, a patient's most recent MR. You can see that there's a lesion, right? Little lesion. T2 kind of intermediate, right on DWI. You can see bone on here.
Does Memorial Sloan do EVIST on livers?
Yeah, but
okay.
This was not done with EVIST. So the way that it's done is if there's a known MET, we switch to EVIST as a follow-up tool, but they don't, like if there's no MET, they don't do EVIST.
So for screening, you don't, like HCC screening, you don't do EVIST.
We don't really do HCC screening.
Oh,
Is there like a cancer referral center so that
yeah,
people already have
we don't
concerns?
screen.
Oh, got it.
This case, I mean, there's a minimal like trickling in occasionally patients, you know, like they have something else and then they happen to have cirrhosis and they'll send them, but not, you know, we don't, you know, we already get them once they're ready to go. Anyway, but this patient,
Victoria, would you call that rim APHE?
right. So you can see that it does have a little bit of that rim APHE, right? Like I know I've talked about it for a while that, you know, if you're not sure rim versus non-rim, you go with rim. But, you know, Lyers doesn't apply here. He has healthy liver, but the concept still applies. So I thought this was rim. And if you look at the delays, right? This is the 1 minute and 3 minute. You can see that the lesion retains its contrast and still has that sort of target-like appearance. And notice that on diffusion, you know, it didn't have that target-like appearance on T2. I don't know, it's arguable. You can argue that probably has a little bit of target-like appearance. So this is the patient's studies. I think this is 6 months ago. And then this is about a year ago. So again, the patient gets MRs because patient had renal cell. So you can see that before, so 6 months ago, this lesion was visible. And let's see, you can see that he was, you know, that sort of rim enhancement kind of was not evident, but it was enhancing. And at that time they kind of thought maybe it's perfusional. You can see that it remains hyper enhancing. So they did not think this was a MET. They weren't sure what it was, but they at the time they didn't think it was a MET. I think the question maybe
Victoria, what was the primary?
renal cell.
Okay, and then no history of liver disease, you're saying?
No history of liver disease. So just, and then this is this one, right? So this one is, so this one is 6 months before. So the one that I'm pointing to is a year before the case that I read and showed you originally. So unfortunately, there's an artifact you can see here that you know, kind of obscures this region. You can see that.
It definitely looks like it's growing, and they have a history
Right.
of renal cell. So I feel like you have to be, and there's a T1 pre-contrast correlate.
Right.
So I feel like you have to say, like, I'm concerned about a MET.
Right. So I was concerned about malignancy, but to be honest, I was more concerned about, you know, ICCA than a MET. Because of this ring-like pattern and retention of contrast and delays, which small intrahepatic cholangios somehow like to do. So, you know, but I reported as, you know, suspicious for malignancy, the primary, such as small adenocarcinoma or metastases, and they biopsy this, and this is intrahepatic cholangio. So patients can develop more than one ugly cancer, sadly.
Yeah. What was their RCC? Was it a high risk? Like
Was it high?
Go down to the kidneys?
So it was resected. Let me stop sharing for a second and grab the original tumor. I'm trying to see if we even had. So seems like here we go.
The reason I'm asking is I feel like that helps me kind of lean one way or the other. Like if you see this kind of tumor and you think about cholangio, METs can also look like that. And so we have to like bring up both in the differential. But if the RCC was like a big aggressive one, high risk, then I would lean towards that.
So this was about a year and a half before the MR. You can see it's here. I'm going back here. It's unclear this, whether this lesion was there. Possibly, possibly not. Small cholangias can grow fairly slowly. I can look up the path if you want, but I'm not sure.
Does that look like a delayed phase? So we're not really getting what we want to assess the like primary to see if it's a clear cell, but clear cells generally like enhance and kind of wash out. The reason I'm bringing it up is like cholangios are just much less common than renal cells, for example. Like
Right.
there's like 10,000 cases in the US per year versus like 100,000 cases of renal cells. So, but then if it's like a small renal cell versus a higher grade, more aggressive renal cell, that would change my pretest probability.
So this is a clear cell renal cell. It was 4 centimeters, unilocular, WHO grade 3, vascular invasion, segmental branch of renal vein invasion identified, surgical margin uninvolved. So, I mean, fairly aggressive. So, honestly, Memorial has this lexicon that we use, right? And we're supposed to use to denote the probability, right? So like, possible means about 50%. I think this is going to be that. Probable is like about 70%. I think it's going to be that. Consistent with is like 95% or something like that, right? Unlikely means less than 10%, which is helpful in some situations, but I actually stopped using this lexicon when providing differential because like I was fairly like if I had to bet, I like my bet was that this is cholangia, right? So like because like untreated, like I would imagine that untreated renal cell met is not going to grow this slowly, although I may be wrong. And then this ring-like pattern to me was more suggestive of cholangia. But then like from patient's perspective, right? Let's say this came back as renal cell, right? My report can be misconstrued as being wrong, even though honestly, even if I said something is less likely, which means 25%, 25% is not zero, right? But from patient's perspective, I don't know. It's like it's almost like it's like that old Russian joke. It's like what do you think that the probability that the meteor is going to strike you down? It's 50-50. So they're going to strike me down or not? So like from patient's perspective, these things don't mean anything. So now I just start providing differential and just say this could be this, it could be that, unless I strongly believe that something is unlikely. Right. It's like if I really didn't think this was going to be a met, I would say unlikely met. But here I just said, neoplasm, differential diagnosis, intrahepatic cholangia versus metastasis. Although if I had to bet, I would have bet on cholangia.
But I like what you did because it is 50-50, like it easily could have been either one. There are signs suggesting cholangia like the rim. But the fact that this is a grade 3 RCC with no background liver disease, statistically, it's going to actually lean towards RCC, right? So I think there's factors in either way. And I have seen that Memorial Sloan Kettering probability scoring, and I was like, wow, that's amazing that they can get so precise. But I think this is like the exact case where you...
Right. So I actually, again, I stopped. Like if I stopped providing using that lexicon for differential, but let's say like if I think like for example for Nelly's case, we would report it as probably like appendiceal neoplasm, less likely appendicitis. Like if I didn't like that's how I would use the lexicon now. Does that make sense?
And that's helpful, right? Like
that's actually very helpful because so this was kind of like I know we're kind of diverting from the case, but so like there's a lot of literature that shows how variable our use of different terminology. So like there are like these 2 nice articles that looked at how we as radiologists, the meaning that we input into all these terms, and then what the clinicians interpret them as, and it's like all over the place. So and then I was at RSNA and I was presenting with Olga Brook, and at the time we were in the same section, and this brought up, we're discussing, and I said, for example, like I say consistent with when I think that this is it. And she looks at me like on the podium, she goes, really? Because I use consistent with when I don't think this is like the actual diagnosis. So I'm looking, I'm like, here we have two radiologists.
What?
Yeah.
I'm with you, Victoria.
I know, but think about it, right? Now here we have two radiologists in the same section, in the same, like we're both body radiologists working in the same section. If I issue a report that says consistent with appendicitis, it is appendicitis. If she issues a report that says consistent with appendicitis, that kind of like maybe 50-50. But how is surgeon supposed to know that? Right? Like they can't.
Yeah, I completely agree with you, but I will say I actually don't use the word consistent with unless I have path proof. So I might say like highly suspicious for, but I would personally, I never say consistent with unless I have path proof. So
Right.
I'll be like, consistent with the pathologically proven, blah, blah, blah.
But you see how different everybody is? So with this lexicon, at least like this variability is eliminated. Now, I mean, like if I reported and say like probably RCC metastasis less likely intrahepatic cholangio, let's say if I reported it, right? Like the path comes back as ICC, technically my assignments of probabilities were incorrect if that's what I did, but at least like I clearly communicated what I was thinking, and the clinician knows like how to interpret what I said. Does that make sense?
I don't think you're incorrect if the path comes back as the thing you said was less likely, like you still said possibility,
Exactly.
I mean, I think ultimately this gets back to like, you still need to biopsy most of these lesions. So like, it's still academic at this point.
Right. So again, like I really started using this like this more in terms of like it not for the differential diagnosis of particular cancer like type, but let's say if there's like a benign versus malignant situation, and I really don't think like for that I would say like probably neoplastic, less likely inflammatory, something like that, like to really to indicate my level of suspicion, but not exact pathologic diagnosis, because exactly like it will look like I was wrong even though technically I wasn't. Anyway.
Hey, great discussion. Nelly, you're up.
This is a patient with flank pain and obstructing proximal right ureteral stone, explaining the flank pain. And the patient got urology went in and did a ureteroscopy and stent. So the stent is right there. There's your stent right there. And then we get follow-up imaging. I've shown a similar case before, but on follow-up imaging, the stent is here.
That's a lot of migration. I haven't seen that much migration.
What?
Nelly,
I haven't seen that much migration.
Or no?
What? Sorry, what did you say?
The stone with it?
Did it break the stone with it?
At least for migrating that low, if it dragged the stone with it.
Yeah. Well, so first of all, this is not any like your typical stent. This
wait, Nelly, is this your resorbable stent?
Yes, this is a resorbable stent. So they get serial. This one probably did migrate too. Look at it's like pretty low, and it looks like maybe it's in the penile urethra. So this probably migrated as well. But this one is an absorbable stent. I showed a case before in the past.
Do you feel like it's like less dense than before? Like, is it like, are we seeing it actively absorbing or?
So
I see striations there.
Yeah, normally like segments of it will just go away, completely dissolve. And then you'll just see segments that are left. And I think there's coils. You see, I don't know if you can appreciate it, but there's like, and this looks different from a non-absorbable stent, more of the typical stent we see.
Nelly,
start-
does it change with time? Like,
It changes.
does-
Yeah. So they
Yeah,
get serial imaging, and over time, like segments of it will just go away. So one time we called it retained fragment because there was the coil just left in the renal pelvis, but it was actually just absorbing. So it wasn't
Nelly,
retained.
how long do they take to fully resorb?
Did we look this up earlier? I think it was like 7 or
I've
8
not
weeks.
seen this case, so if it's different.
Oh, okay. So this is I think it was like, was it 2 months? 3 months? I forget exactly. But this is the follow-up, and you see that like most of it is gone already.
Oh, wow.
Yeah.
Nice.
So just keep it in the back of your mind. And it looks different from absorbable stent.
Super cool. Okay, Roopa.
Okay, do you see the scout?
Yes.
Yes.
Okay. What do we think of the scout?
There's a lot of fullness over the perineum.
Yeah, I feel like there's like some rounded thing over the
Like the scrotum is really thickened and edematous.
That's fine. That's fine. That's normal.
Oops. And then I guess there's like a paucity of bowel gas in the lower abdomen.
There's like bubbly gas in the right upper quadrant.
Okay, good.
Oh, an internal hernia?
Okay,
Or
what other
pneumatosis.
things? Okay, or
I think of pneumatosis. I think it's like malplaced small bowel.
Yeah,
Okay.
malrotation. That could be it. Yeah,
I thought it was a
great.
big bad cluster sign with liver abscesses.
But it's lucent.
Yes. Okay, here's the CT.
Retained sponge. Oh,
No surgery.
Like
pneumatosis.
these?
Yes.
So it's like colon in front of the liver.
Mm. Pneumatosis in that interposed colon, and then small amount of like free air. Yeah, I'll pull up a coronal.
Nelly, you were right. Pneumatosis.
Yay.
Yes. It's just a nice scout case. So this one was interesting. They had a colonoscopy where they thought some of this was some kind of a duplication cyst, which is why they wanted us to image this. And then I think we called it benign pneumatosis.
No. We were not sure because it was called as free air.
Right.
And the patient was totally asymptomatic. But
Are there a lot of diverticula there? Like it seems like it's like a chylodides with a lot of diverticula.
No. So they ended up getting a right hemicolectomy, and in the path here, I'll read the paths. They say segment of colon with numerous mural cystic spaces lined by foreign body giant cells consistent with pneumatosis, cystoides, intestinalis. No dysplasia or malignancy.
Wait. Go back. So pneumatosis, cystoides, intestinalis is associated with foreign bodies? I didn't know that.
Foreign body giant cells.
What does that mean?
I don't know. That's a path report. They found too many giant cells is mine.
But it does look like there's like either diverticula or pneumatosis cystoides, right?
But
like
it's very
large...
segmental though, Aarti. There's no diverticulae elsewhere. It's just
No. I'm saying like I see how it's like pneumatosis cystoides, right?
Yes.
Those large ones, and then those can actually have air that dissects out.
Yeah, this is probably like one of them popped and air is just localized to this. It's that pretty pneumatosis we say, right?
Yeah.
Yeah.
But I didn't know that cystoides.
Yeah, it can have foreign body giant cells apparently. And we always say these are asymptomatic, they can be left alone, except this patient ended up getting a right hemicolectomy for whatever reason. That is a big surgery for that, right? If we keep saying these are benign.
Yeah. I mean, probably this is, what was their symptoms?
So this was done after a colonoscopy. So it was just a screening colonoscopy where they thought they saw some polyps and what they thought was a duplication cyst. But it's clearly not cystic at all.
On the first biopsy, on the colonoscopic biopsy, they called it a possible duplication cyst. which is why I think they had a hemicolectomy.
So you're telling me that basically this patient had surgery for an incidental finding that wasn't symptomatic.
Yes.
Which is exactly, yeah. So
unfortunately.
So we pulled up this radiopedia, which shows us causes for benign pneumatosis. And then 15% of them had no known cause. In his case, there were no other associated coexistent pathology. So his was incidental, but yet he ended up with a big right hemicolectomy, which is what was interesting.
Very interesting. Can you show the plain film again? I'm just curious if we can actually see the pneumatosis on that plain film.
Pneumatosis cystoides intestinalis, like the bubbles are big. Like,
Yeah,
Yeah.
it's like very like a macroscopic and segmental form of it, right?
In retrospect, would you guys have called pneumatosis here or?
yeah.
I don't know.
It looks very
I mean, I would
ugly
suggest
large.
it and say get a CT.
Well, I mean, you got it right, Nelly, even just on the scout. So
Good for you, Nelly.
Better to be lucky than good.
Yeah.
I think
Okay.
it's called an internal hernia, but anyway, we can debate later. We'll give it Victoria's probability score and okay, go.
All right. This patient came in with abdominal pain.
Ahaustral colon. Oh wait.
Yeah. Go ahead, keep going.
Ahaustral colon with
Like on the left, right here.
inflammatory changes. It reminds me of UC, like a lead pipe kind of thing. Fecalization distally. There's a stimulator.
Is the appendix abnormal again?
Appendix is, where is it? It's
A
right
little
here.
hyper enhancing.
Yeah.
It's fine. Yeah.
The TI looks
It's-
a little hyper enhancing.
Is that the TI, Nelly? Oh, okay, that's the
Right
TI.
there.
Okay. So Crohn's.
Yeah, and that's what was read. Inflammatory, bowel disease. Oops, this is a post-op. So patient actually had acute abdomen on exam. And so they took the patient to the OR. And this was this is post-op, but the pre-op, it was all necrosis. Necrosis of the distal transverse colon through the distal sigmoid colon with 2 segments of full thickness necrosis at the splenic flexure and sigmoid colon and contained perforation.
Like
that
from
was
ischemia? Can you show the original
ischemia.
again?
Yeah. Let me. So and if I were to have read this case prospectively, I mean, I probably would have said something along. Now, actually, I don't. I give a differential and I say, I mean, it's my infections, inflammatory, ischemia, and I feel bad saying it because it's such a broad differential, but I do because of cases like this. I mean, I didn't read this case prospectively, but I would still put those in my differential.
But Nelly, on this coronal, don't we see enhancement?
Yeah, but this was proven necrosis.
I actually,
and I'm here because I
believe
wanted
it.
to. I agree with you. I wanted to know like what features would have leaned us towards necrosis versus inflammatory.
But
If
Nelly,
anything,
when
that's
I do
right.
see like a transition at the distal transverse or splenic flexure, I do think that's like, because that's the watershed area, we should keep that in the differential, like when it changes at the splenic flexure. But the other tricky thing here is that like the rest of the vessels look great, right? So when you think about ischemia, you're like, oh, do they have bad atherosclerotic disease? Is there a thrombus? But these vessels look beautiful, so
But
like
most causes of ischemia is low flow ischemia.
low
It's
flow,
not
yeah.
embolic,
So
right?
was there
It's not.
sepsis? Was there a cause for like low flow?
Patient, I mean, has a lot of comorbidities. Like the patient has diabetes, has the heart stuff, like you mentioned. Let me see what else. There's patient. Yeah, patient is not. Yeah, a patient does have like other comorbidities. So I don't know if that contributed to it or there's like a lot of stuff happening up north.
Nelly, will you show axial through that
Yeah,
that
course.
pneumatosis-like area.
Wait, there was no, wait, was there pneumatosis? Oh,
I
sorry.
thought you said that left
Here.
sigmoid colon wasn't.
I didn't see
Didn't that
pneumatosis.
bubbly pattern look ugly?
Where?
Where did they say
I
the
think that's just like
necrosis?
fecalization.
Okay.
Oh, fecal. Oh, here you mean? I didn't see
Yes.
pneumatosis, but
Okay.
the surgeon did report there was full thickness perforation at the splenic flexure and at the sigmoid, but I don't see it on imaging, like looking back.
Wow, it's tough.
It could have happened after this too. Like, what was the delay until surgery?
One day, next day.
Yeah. So it could have happened after this. But
We've
yeah,
had a
this is
few
really good reminder.
hypotensive patients like this with like Aarti said, clean looking vessels, but very fluid filled dilated colon where you couldn't tell how the wall was and ended up being ischemia from hypotension.
Yeah. And you can, like, I think there's different phases of ischemia, right? So, like, maybe this is the early phase, and when you see lack of enhancement, that's more of the late phase.
Agree. And all this fluid-filled atonic kind of appearance is also
Yep.
ischemia, but
Yeah.
like you said, like you kind of have to give the differential, and then if they're like, yeah, they have no history of inflammatory bowel disease and they're pretty sick or they have these other comorbidities, like definitely ischemia is up there.
Yeah, and I don't not put ischemia.
And
Because
Nelly, do you have a lactate? Because I
um
usually put like correlate with lactate.
right. I mean, and if they didn't have what I didn't read this. I read the post-op CT. And I don't know if they had lactate at the time because the patient came through the ED and this was the ED study. So I don't know if the lactate was done. I'm sure it was done. I don't know what the level is. But I would, yeah, I agree with you. I would say, correlate with lactate level. And this patient had like surgical abdomen, like on exam. So that's why they took the patient to the OR and found what they found.
And just quick curiosity question, what was that stimulator in their abdominal wall?
Oh, it's the epicardial leads, I think, for her heart.
Oh, so it's
It's
like
going to her heart.
Okay, got it. Okay, so this is a patient with a positive pregnancy test. You see their uterus here. And we've got some fluid in the endometrial cavity. And then this is what their endometrium looked like.
It's like a molar pregnancy.
Yes, good. So yeah, there's this big heterogeneous cystic and solid lesion in the.
Oh, there's patient information on the top.
Okay, so there's a big cystic and solid thickening of the endometrium. And actually their HCG, it wasn't just a positive pregnancy test, then they got the quantitative and it was 150,000. So super, super high HCG, no gestational sac and fetal pulsing. So and then this big mass that's like cystic and solid. So they ended up doing a DNC, and this was actually a complete molar pregnancy with no fetal parts. So molar pregnancies are actually when you have mostly like the sperm proliferating. The egg is usually like the chromosomes from the egg were not taken. And so it's usually like mostly sperm tissue. A complete molar pregnancy is when there's no fetal parts, and a partial mole is if you saw something like a large mass like this, but then also a fetal pole and like a pregnancy in there as well. And usually the HCG is like really, really out of proportion, like super, super high. In this case, it was 150,000. They were able to do a DNC, and then this patient recovered and actually had a completely healthy pregnancy afterwards. So anyway, this was just an example, rare example, very rare, but this was a complete molar pregnancy. And I'll show you a cine, just it's, oh, let's see. So you can choose like very thick, very heterogeneous, cystic spaces, solid. Yeah.
This is an MSK study, and there was an incidental finding in the bladder on the MSK MR. So what do you guys think? And they wanted to know if this was like an utricle cyst.
It's pretty high.
Yeah.
Cyst is usually midline in the prostate, mid-prostate.
Mm-hmm.
Is it related to the prostate? Oh, it
It
is.
is.
Is it a Brunner cyst?
Yes. So it's a Brunn cyst. Brunn cyst?
Yeah, Brunn
Brunn
cyst.
cyst.
Yeah.
Brunn cyst. Yes. So here's an example of ultrasound. It looks just like ours. It's anterior. It's at the bladder neck. So the other differential consideration is ureteral seal, but ureteral seals are posterior, like where the ureteral orifice inserts, and this is anterior. I think you can appreciate that best on the Sag here. It's more anterior and it's at the bladder neck. So this is a Brunn cyst. I learned about it for the first time when I was looking at this case. But it can lead to bladder neck obstruction. As you can imagine, there could be like a ball valve effect when the patient urinates. It's due to inflammation of the Brunn's nest that's within the urothelium. These are completely benign. And in this case, just an incidental finding, but they can cause lower urinary tract symptoms, obstructive lower urinary tract symptoms.
Nelly, I have to admit, I feel like I cheated because I just learned about this last week when my colleague Hernan showed an example of it. So I do have a companion case and I'm going to show you guys right
Oh,
now.
wow.
Hold on. Okay, so we stopped recording, but Nelly was like, it looks just like mine. And I think we actually read the same paper that you read, but it literally was like, okay, what is the cyst at the top of the prostate going into the bladder here, right? So very cute. Yeah, there it is. So it's just incidental. We don't do anything about it, right?
Correct, unless it's causing obstructive symptoms.
Cool. New for everyone, including us. I literally learned about this last week. Brunn cyst.
I was so impressed. I was like, wow.
Better to be lucky than good. Okay.
Great. This is, yeah, what do you think this is? And what questions do you have?
Or paraganglioma?
Just neuroendocrine. Oh, that's a good one.
Wait,
Yeah.
it looks kind of like class line with the pancreas more than
Yes. So yes. Stick to pancreas.
Okay, could be SPEN, cystic and solid mass arising from the pancreas. Neuroendocrine SPEN. Is this male or female?
Female.
Less likely MCN because usually that's body tail junction, less solid components. Thinking SPEN and neuroendocrine. How old?
Yes. So the 24, 20s, sorry, 20s.
SPEN, then
SPEN. This was SPEN. So this is the patient got a Whipple and it was a SPEN. So solid papillary epithelial neoplasm. Is that what SPEN stands for?
Some people use the epithelial, some people don't. Solid
really?
papillary neoplasm, but show the coronal because you said they got a Whipple. And it's really important to describe the relationship to the ampulla to see if they truly need a Whipple or if they can just carve it out without doing a Whipple.
Oh, okay. So, I'm sorry. I'm not sure if they got a Whipple or not. Let me see. Actually, we have post-op images, I think, don't we? Yeah, they got a Whipple. Yep, it was a Whipple.
Actually, this is really nice to show Whipple anatomy because I think it's really confusing for trainees. You can see that.
Yeah,
beautifully see the pancreas right there joined the jejunum. Yeah,
so here's a pancreas here, and then with the Whipple, the head is removed, and then there's a jejunum here. So there's 3 anastomoses with the Whipple. So you have the first one, which is the jejunal and pancreatic anastomosis, and there's a hepaticojejunostomy. So they take out the bile duct, so then they connect the jejunum to the whatever remnant of the bile duct is there. And then the third anastomosis is a GJ, so gastrojejunostomy. So here it is. Here's a gastro, and then here's a J, GJ.
Perfect. Thank you for pointing that out.
And then the anatomy, you were saying they could just carve it out. So the ampulla, let's see here. Well, it's probably here because here's a common duct. So there's the ampulla. So it's right next to the ampulla.
Yeah, it's too close. It's too close. So that's why they had to do the Whipple.
Yeah, got it.
And any oncologic resection, they want to get like 1 to 2 centimeter margin, R0 resection, no tumor at the edge. But spens are low grade neoplasms. So a lot of, it's like you need less of a margin than a true adenocarcinoma, but that one was really close. So they probably just needed to be safe.
Aarti, I can show a quick, like a classic spen. We just had one. So
Yeah.
And they could be solid, they could be cystic, and they could be solid cystic. So it can come in variety
the whole screen.
imaging features.
Yeah, so Nelly, when they're small, they tend to be solid and smudgy enhancement because the pseudopapilla are all packed together. And as they grow larger, they outgrow their like little vascular supply in the pseudopapillae, and they tend to hemorrhage centrally. So even though they look cystic and solid, they're more like solid and hemorrhagic.
Mm.
So this one read the book, 20 years old, female tail lesion.
Yeah, this one actually
specs.
looks pretty solid still.
Very
It
solid.
does. Look at the
Doesn't
T2,
look like
like
it's
it's
Oh,
almost
now
like,
they're cystic. There's your hemorrhagic component, Aarti.
Yeah, wait, show me the T1 free.
yeah, it's some outside study. So, but there is a lot of
Oh, there it
hemorrhage.
is.
Yeah, look, they read the
Yeah.
book.
Yeah, that's what I said. It's very classic.
Yeah, lots of
Calcifications, hemorrhage. This is all. The black stuff is all hemorrhage on the T1.
Right stuff.
On the T2.
Yeah, so
so-
people tend to think like, oh, it looks really, heterogeneous. Like they tend to
Right.
call the cystic part necrotic and think it's aggressive, but it's actually low grade and it's more hemorrhage because it's just like very delicate vascular supply. So
Yep.
cool.
Awesome cases.